Welcome to our USMLE Step 3 review with Dr. Adam Goodcoff from See the Med Life. Please check out his channel, TikTok, and Instagram in the description below. We hope you enjoy the video.
Welcome, everyone, and thank you for coming to this Zoom. The question is on the screen. We're going to be doing a little bit over 10. I forget how many I put in here, 10, 15 questions or so, but we'll kind of walk through them, hit on some of the high points. 13 at the top, it says. And so we'll walk through these, answer questions as we go, and hopefully learn something and get a good look at some of the things. Again, this is a very basic overview of what BoardVitals has to offer. Obviously, as a question writer, I've seen thousands of questions here. There's a very deep a depth of knowledge across the bank, and really interesting images and links and things to really solidify your knowledge. So we're going to go ahead and get started. I think the best way is for me to kind of read through these questions, and then we can answer them. We'll answer them via the chat function. So no need to worry about muting and unmuting yourself. Just type your answer in the chat. Try and wait until I finish reading the actual question. Once I'm done reading the question, feel free to fire away your answers, and we will pick what looks to be the most popular answer. So this is a 55-year-old gentleman. He has a 5-year history of decreased social awareness, disinhibition, attention deficits, and personality changes. So they do a path exam of his brain, and they see frontotemporal atrophy, gliosis of the frontal lobe, white matter, characteristic intracellular inclusions, and swollen neurons. Also, we do not see the amyloid plaques and neurofibrillary tangles. So this is kind of a clinical way to ask a pathologic question. Which of the following conditions did this patient have? So read through your answer choices, and once we go through this, I'll tell you actually a little bit about how I go through a question, how I approach a question as someone who has written questions in the past, because the way that we just did that is not the way that I would approach it. And again, I will keep an eye on the chat. I know names show up and things in the chat. Don't worry. If you want to send it to just me instead of everyone, that's fine. This is a learning environment. We're all here to support each other. If you're new to the MedLife or anything with me, it's always a team learning environment. We never negative energy. So don't feel bad about getting something wrong. It's actually how you learn the most. So I'll give you guys a few seconds to take some guesses here in the chat. Seeing some interest in C. Anyone else want to put in a guess before I kind of break down the answer here? Some more interest in C. Okay. All right. Yeah, and it is kind of hard to see the screen. Maybe it's the way that I have it viewed. Let me see. Oh, it's a little bigger for me. Yeah, if you change it to standard view, I guess it works a little better. So let's go ahead. The general consensus here is C. So we can select C, and let's see what happens when we do that. And so we select C, and unfortunately, that is not going to be correct. So let's go ahead and try and put D for this, pick disease. And you should see that when we check the answer here, pick disease is correct. And let's take a look at the explanation. This is also known as frontotemporal lobar dementia, and it's important that you know the this is considered an eponym, pick disease. It's named after someone. It's an eponym. But the frontotemporal lobar dementia is really what's more important to know here. And the name gives it away, fronto and temporal lobar dementia. So if we look at the question stem kind of back at the top, this patient was having, and if we can just scroll up a little bit here. This patient was having decreased social awareness, disinhibition, attentional deficits. So he's got these kind of strange symptoms. For someone that's 55 years old, that would be pretty abnormal. And, we're fortunate in this case that we're able to do a pathologic exam, for the purpose of this test question. Obviously unfortunate for the patient. And we see some very characteristic findings. So I want you to read that second line, shows frontotemporal atrophy. So if you knew that Pick's disease was frontotemporal lobar dementia, well, you now know there's frontotemporal atrophy. And in the first line, we have these strange personality changes that don't fit with a 55-year-old. Things, at least in my mind, that I associate with a 50-something-year-old male that has a sudden decline is Huntington's disease and then everything else. And this is kind of getting into the anatomy of how I go through a question. I start with the stem, which is the actual or I guess interrogatory, which is like the question here: which of the following conditions did this patient have? I always start there. Reason being, that's going to tell me what I'm looking for in the stem of the question. These tests are timed, the standardized tests. And so, as much as it is a test of your knowledge, it's a test of your ability to navigate an exam, manage your time, and get through this exam effectively to get the highest score that you can. So what I do is I start there. What am I looking to pull out of the actual stem, which is above that section? So I start there. This particular interrogatory or question segment is not going to help us. Which of the following conditions does the patient have? It's not going to give us any boost. We need to really read the whole stem. So what I do before I go to the stem is I just scan through the answer choices. And I'm just looking quickly to see what kind of diseases, and this is the perfect example. So we go through HIV, dementia, Alzheimer's disease, Creutzfeldt-Jakob disease, PIC disease, B12 deficiency. So I know this is going to be something neurologic. Something in this stem is going to point me neurologically. Now, the other reason I go through the answer choices before I even read the stem is because, as you know, studying medicine, it is incredibly broad, and there is so much knowledge base that you're going to be tested on. And if you go into a question with too open of a mind, you're going to spend time and brain power thinking about things that the question is not even going after. So by reading that last line and then reading those answer choices, you're really starting to hone in on exactly what this question is looking for. So now we know we need to diagnose the patient, and we know it's going to be something neurologic. So now in that order, we go back up to the top. We know they're 55 years old. They've had a slow 5-year decline, and they're having that decreased social awareness, disinhibition. So they have these weird neuro symptoms and frontotemporal atrophy on the autopsy. If you know your pathology really well, you'll see the gliosis of the front white matter and these intracellular inclusions. To be honest, without knowing any of that pathology, you can get this question right by knowing the name of the disease. So we kind of took something that seemed like that should have been a step one question and broke it down to how it's actually a really clinical question, and they really gave you the answer. They just want you to recognize that, yes, this is going to be some type of a neurologic degenerative process in the brain. Let's figure out which one, and here we go. So if you are interested in reading more, of course, you can check out the explanation below. And these questions are really nice because they break down why each of the incorrect answers are incorrect. And when you're studying, if you do get a question incorrect, it's important that you really look at every single choice and figure out, if you ruled that choice out, did you rule it out for the right reason? And if you did not, if it was something you were considering, what was the explanation that changed your opinion after the fact? So I know that's a lot. The other explanations will not be that long, but it's really important in my mind to understand the anatomy of a test and a test question and how to attack them, because that's really probably 30 to 40% of your success on exam day is understanding how to go through this process. So we'll go ahead and go to the next question. And of course, I saw some new faces pop in. Thank you for joining us. Just let me know in the chat if you have any questions as we're going along. And of course, I will read the question and then drop what you think, A, B, C, or D, or however many letters there are, drop what you think it is in the chat, and we will then answer it together. So in this question, we have a 24-year-old female. She's coming into labor and delivery triage with contractions every 3 to 5 minutes for the past hour. You know what? Let's pause. Let's do this. Let's do this the way that I just recommended, and we'll kind of get into the habit of doing that together. So let's read the last line. Which of the following statements is the best answer regarding Group B strep screening and treatment for this patient? So we know that this is going to be a Group B strep question. If you're studying for step 3 or even step 2, this is a very high yield topic. It's why I picked this question. You will see one of these on test day. And so looking through the answer choices here is probably a little bit lower yield, because we know we need to find something about screening. They're going to give variations on the screening recommendations, but we'll just scan through them. So do we need antibiotics? Do we need a culture? There's something about allergies here and so forth. So not going to be super helpful, but we know what we're looking for at least. So we go back up. Now let's read again. A 24-year-old woman presents to labor and delivery triage with contractions every 3 to 5 minutes for the past hour. She is from out of town and does not have her prenatal records. Uh-oh, shocking, right? They already told us we're going to be looking for some type of a tough GBS situation. She reports that this is her second pregnancy and she's approximately 35 to 36 weeks gestation. She cannot recall information from prior prenatal screenings and denies any allergies. On exam, she's afebrile and her vital signs are stable. A cervical exam reveals that she is 5 centimeters dilated and 60% effaced. So we're referring to the cervix itself, and fetal heart tracing is reassuring. Now, again, if you didn't read the stem below, there's a lot of information to take in there that your brain is going to be trying to process, because they could ask about anything. You'd be looking at 3 to 5 minutes for the past hour for your contraction duration, that she's about 35 to 36 weeks. You're trying to figure out, is this premature, or is this going to be a steroid question? Then you're understanding that there's maybe inadequate prenatal care or inadequate understanding of prenatal care. Then they're asking about a cervical exam. So it could be anywhere. And then they throw in the fetal heart tracing at the end too. And so again, by reading that last line, you already know none of that really matters right now. What matters is GBS. And so this patient, well, I don't want to spoil any more. So go ahead and let me know your answers in the chat. And then we'll talk about this a little bit more. But this is you will see this on test day. JB is saying initiate antibiotics. No need for GBS culture. Does anyone else want to jump in? That's A. And welcome. I see it looks like Queen is joining us here. Thanks for joining. Anyone else? Again, just put your answer in the chat. Don't feel shy about doing it. And if you are feeling shy and you want to message it to me directly, just change your to from everyone to my name, and you will be able to message that answer directly to me. GJ is also thinking it might be A. I'll give maybe another 15 seconds or so here, and then we'll get into this one. But it looks like either way, unless we get a massive outpouring of votes, I think we can go ahead and put A here and check our answer. And you guys did a great job with this question. So we went through it, like I said, a little bit differently, and we can look at the explanation, but you are exactly right. Penicillin is a very low risk drug as a whole. And so if there is a patient who doesn't know their status, they haven't had testing, they're in active labor or close to, they're 5 centimeters, 60% effaced and having frequent contractions here, they need to be treated. And you can see the ACOG guideline down here, specifically, defining, let's see, 36 to 37 weeks needs the vaginal rectal culture. And this is kind of if you remember from your OB, this is the question mark culture that you do. So kind of important to remember those things, tease out all of the knowledge that you can as you're doing questions. Any of the times that you can tie things together in your studying are going to help you solidify that like neural network, as they're referring to it now in the literature, that we're like strengthening these connections every time we access information like that. So that was very well done. And hopefully you could see how going through the question in that manner makes it a little bit more straightforward and saves you time. So again, a very straightforward question, a guideline question. You absolutely need to know your GBS screening and all of your pregnancy ACOG guidelines. So we can go ahead to the next question. And we will jump in on this one. We got to scroll up a little bit. So this one doesn't have the last question line separated. So we'll just find the last period and read that sentence. So which of the following is the most likely diagnosis? So again, that line doesn't help us. So we have to go down and take a look at the answer choices. So taking a look at A, we have esophageal rings and webs. B is Mallory-Weiss syndrome, echolalia, esophageal varices, esophagitis. Okay, so obviously there's going to be some kind of a GI question, something in the esophagus. All of these are esophageal conditions. So now we scroll back up and we know we're looking for our clues to getting us, what's going to be the answer here. So we'll scroll up. Let's read our stem here. This is a 47-year-old gentleman, history of dysphagia, episodes of chest pain that are induced by eating. He has frequent spontaneous regurgitation of undigested food from the esophagus over the past 6 months. And now, that stem alone, we can come back to this, makes you think of one thing, and I don't think it was an answer choice if I remember. We have a barium study here, and this is what's considered pathognomonic. That's why I included it again. This is one of the great images. BoardVitals has a ton of really good images in their banks, and this is an image that needs to be burned into your memory. So we'll scroll down just a little bit more so we can see all the answer choices, but We can see the image there, right? So this is a chest x-ray that's been cropped, but we can see contrast in the esophagus, right? I know sometimes there's delay. Usually I'd ask, but you guys are doing a great job already in the chat of putting in some answers of what you think it is. So a lot of people are voting for achalasia. And we can go ahead and select achalasia and check that answer. Does anyone want to, and you guys will be correct on that, does anyone want to comment on what, without the esophagram, what the other condition that I was referring to with a kind of a middle-aged male regurgitating undigested food, what does that make you think of? And again, I don't like buzzwords, but that's like a very classical. The other thing that I could add on to that would be that he's regurgitating undigested food and has very foul-smelling breath. That's when you hear that, that's a yes, bingo, GJ, Zenker diverticulum. So that's kind of like an outpouching between the pharynx and the esophagus that's going to store actual food, and it's really disgusting. It actually just sits there and rots, and it smells awful. And so this is a case where you read the answer choices first. You read that line, and your brain might think, "Hey, this might be Zenker's," but you already looked at the answer choices. That's not an option, so you can just let that go and start focusing on what the answer is going to be. And again, this one slam dunk on the easier side for questions, giving us the image as well. It's a nice, easy picture of achalasia. So great job with that one. And again, you can see, reading through some of the explanation here, you can get into some of the treatments and why this happens. And so it's kind of cool if you want to do a deep dive and solidify your knowledge there as well. So very good. Let's go ahead on to the next one. Okay. So we have a 28-year-old male here. Again, we're going to pause and jump down to that stem. Which of the following is the most effective long-term treatment for this patient? So we don't know what the condition is. We're going to take a look, and I'm just going to scan these. Alprazolam, CBT, buspirone, bupropion, imipramine. I'm not a psych pro, but I know these are psych drugs, right? So we need to find out what kind of condition that we're treating with these psych medications. So we have a 28-year-old gentleman. He's complaining of stress. He's worried about many things over the past year, including his health of his family, his future financial stability, his relationship with his girlfriend. So he's got a lot going on. He often experiences a tingling sensation in extremities, especially when he focuses on a particular topic that concerns him. On a few occasions, he's experienced some shortness of breath. It subsided when he took deep breaths and had a few shots of vodka. Wow. He rarely drank alcohol prior to experiencing these episodes of shortness of breath. So we'll get into why that's important. On presentation, he appears anxious. His hands are warm and sweaty. So what are you thinking here? And this one, I have a feeling maybe we'll struggle with this one. So go ahead and put your answers in. Some things to kind of call out in the question here. He's using alcohol to cope with this condition. And if anyone wants to comment too, what is the condition? What condition are we treating here? Because that's right. This is what we call like a second order question. So they're giving you the diagnosis in the stem by telling you about it. And then they're asking you, what are we going to do to treat that? So you need to know 2 orders of knowledge to be able to get this correct. So I'm seeing a lot of choices here for alprazolam for generalized anxiety disorder. And this is good. This is good. Anyone else want to put in some answers here? Generalized anxiety. B, we have JB voting for cognitive behavioral therapy. Okay, good. So we'll have a little bit more discussion on this one. So more folks have voted for alprazolam. So let's go ahead and put alprazolam for this one. And we will see that when we check that, it's actually going to be incorrect. And the reason being is that alprazolam is an abortive therapy for an acute anxiety attack, an acute panic attack. In some patients, and this is a difference in what you're going to see clinically versus what you're going to see on the exam. So let's go ahead and switch it over to B, which is the correct answer, cognitive behavioral therapy. And there's a couple really good learning points here, but what you see in clinical practice is not always the actual test right answer. It doesn't make what that physician is doing incorrect. It's just what their practice is or what works for that patient. But on test day, you're expected to go by what the textbook says, or in psych's case, what DSM says. And the other big key, let's look at the line that's highlighted. Which of the following is the most effective long-term treatment? That's really important. There is a difference between the most effective treatment, the most effective acute treatment, and the most effective long-term treatment. And for every disease, there's varying importance of knowing those things. But in this case in particular, the reason I called out the vodka is that, as I'm sure you know, alcohol and benzodiazepines are not a good combination. And so this patient is already coping and has developed a coping mechanism with alcohol use. Um, we have called out whoever wrote this question, did a nice job, and said, what is the long-term management? So they're tipping you off. This person's already drinking. They're already at high risk for abuse of their alprazolam. You don't want to give them this drug long-term. It has a high potential for abuse. And so cognitive behavioral therapy is most likely to help them, with their anxiety in the long term. And so again, a very nice detailed explanation down here if you want to go into what generalized anxiety disorder is, and nice job nailing the diagnosis. But yes, so it seems like minutia. And as you start to do questions like this, look for these tips. And these are things I see, you guys are liking that tip. And maybe I should, cover this stuff more on social media, because this is really, I think, what separates the average test taker from the excellent test taker is picking up on those small things on your first read through that save you from going back. So we can go on to the next question, but those are things you want to look for. It's not in every question, but they're very helpful. So let's read our last line. What is the most appropriate treatment for this patient's presumed diagnosis? So we need to know what the diagnosis is, and then we need to know the treatment. Let's take a look through our answer options. So we have levofloxacin and metronidazole for 14 days, a single dose of ceftriaxone, IM. We have cefotetan plus doxy. We have cefoxitin for 14 days, or azithro and doxy. So whatever this question is, we've got some kind of heavy-hitting infection that we're going to need to treat. So let's go ahead and read our stem now. So this is a 20-year-old woman. She's coming into the emergency department with increased lower pelvic pain and vaginal discharge over the last several days. On exam, she is febrile to 103.7. That is a legit fever. Her blood pressure really soft, 84 on 66, and her heart rate is 121. So before we go any further, this is the ER doctor in training in me, sick or not sick, right? This patient's very sick. Hypotension, tachycardia, and a fever, septic shock, really. Pelvic exam demonstrates profuse yellow-green discharge and severe cervical motion tenderness. So what are some of the conditions that you're thinking about? You can let me know in the chat, or just think them to yourself, because the differential is broad here in pelvic pain, but there are some things that are, very concerning in this patient that we need to be aware of, and obviously that we're going to treat. And go ahead and start putting your answers in. And in a question like this, if you don't know, because this is a tough one, if you don't know the antibiotics per se exactly, you don't know exactly what you need to use in this case, go through and rule things out, right? So again, it's kind of a neat process. Yeah, PID is a great thought here. But do you think that, so like, for example, a single dose of ceftriaxone IM. Ceftriaxone is a great drug. When people are pretty sick, we give it IV. IM is fine, but we're probably not going to be giving someone this sick a one-time dose in their muscle. They're probably looking for some type of an IV medication at this point. So that's probably not the answer. Azithro and doxy can be one combination regimen for outpatient therapy of an STD. This is, again, not somebody who's going home from my ER. So that's probably not the answer either. And so even if you don't know what the answer is, we're now down to 3. It's either going to be A, C, or D. And so we can kind of take an educated guess as to what we need to do. Getting a lot of answers for C. So it looks like let's go ahead and choose C. And let's check and see if we're correct. Nice job. So that I'm impressed. That's actually a really tough question. I put it in here because it's a hard antibiotic question. I want to prove that it's not always as easy as choosing a class or something like this. This is a question you really had to think through. Nice job nailing the PID. The other thing that I think of, and it is mentioned down here at the bottom of that paragraph with this patient, you always want to think of some of the worst things that you could see. This could also be a tubo-ovarian abscess, which is also very dangerous, can make them very sick. They're going to need IV antibiotics, of course, and you can see there's CDC guidelines down here for cefoxitin or cefotetan, and then adding the doxyon as well. So, maybe you don't know, I don't know the CD guidelines, to be honest, the CDC's guidelines off the top of my head. This is something I would actually look up. And that's totally reasonable. On test day, you can't look up, but what you can do is be a smart test taker, knock out the things that don't make sense. And then again, levofloxacin and metronidazole is very broad. It's kind of saying like respiratory, something maybe long above, and then anaerobic for like they say metro below the diaphragm. So that doesn't really fit here either. So realistically, you were between C and D, and you did a great job. So nice work with that question. We can go on to the next one here. All right. So again, this is a long stem, and on your exam on test day, there are going to be quite long stems. And so it's important, again, to use this method. So what is the likely cause of this patient's infection? Cryptococcus, enterovirus, E. coli, Mycobacterium tuberculosis, or Streptococcus pneumoniae. So we have a pretty broad, right? A lot of these, if you're thinking like a test writer, what do most of these or a lot of these bugs here have in common? They can be seen in patients who are immunocompromised. Now, anything can be seen in someone who's immunocompromised, but these in particular, just kind of the flow, having tuberculosis and strep pneumo on the same one with crypto, that's kind of like, all right, it's probably going to be someone with HIV in this question, and let's find out if there is. So we go up to top. A 25-year-old man presents to the emergency department reporting a severe headache that began 1 hour ago. He also diseases following unprotected intercourse, but all of the tests were negative. Temperature is 102. His heart rate is 100. His respiratory rate is 20, and his blood pressure is 105 and 70. Physical exam shows involuntary flexion of the hip and knee when the patient's neck is flexed. Immediate LP is performed, and CSF analysis shows glucose of 20, so that's low, a protein of 100, that's on the high side, leukocytes of 1,500 cells, and there are 90% neutrophils. So did this person end up having HIV? Right? No, they don't. They have no, and you could see again, I picked these questions a while ago, but as someone who does write these, reading through them, I'm thinking, okay, this could be something to do with HIV. And in that stem, they gave me all the information I needed to know that this was not a sexually transmitted disease in immunocompromised patient. So they said no past medical history. Then they specifically went further to say, hey, put it out of your mind. They were recently tested for STDs and were negative. So that is not what's going on. And again, as you start to learn the tricks of the trade, that's why those things are in there. Remember, there's no wasted space in a question almost all the time. Everything's there for a reason. So go ahead and start dropping what you think the answer is here. Yeah, and I don't think anybody's confused that this is going to be a meningitis, right? This has a Brzezinski sign. I'm sure they would have a positive Kerning sign. I think it was actually, no, it looks like Brzezinski, but yeah, very good. I see a lot of E's. Let's go ahead and select E. So strep pneumo is a very common cause of meningitis. And I think you guys did a really good job with that one. And again, when you get a question like this, nice job working through it. It's a long stem. We nailed the diagnosis, but now challenge yourself. How do I treat that? What would I need to give this patient to treat them with antibiotics? And I'm not sure if that one's in this explanation. Move, we scroll down a little bit. It may be here. We can see. So it just says empiric antibiotics and dexamethasone. The dexamethasone, actually, we won't get into it, but that's a plus or minus on that one. But okay, very good. So nice job with that question, and we can go on to the next one. All right. So let's see, what is the next step in management? So that interrogatory component not going to help us. Let's take a look at our choices. Start IV fluids, get a CT scan, offer reassurance, order a Meckel scan, order an air contrast enema. So just reading, again, the first or the last line, I should say, didn't help. And the first couple answer choices didn't help. I had no idea what the question's about. But as we start to get down, we see offer reassurance, order a Meckel scan, order an air contrast enema. That's almost guaranteed going to be a PEDS question because those are things that happen often in PEDS. You reassure the family or you look for one of these PEDS GI concerns. So let's take a look. A 15-month-old male presents to the emergency department with a 4-hour history of abdominal pain. The parents report that every 20 minutes or so, he screams as if he's in pain and pulls his knee up to his chest. Between his episodes, he is glassy-eyed, appears tired, and is refusing to eat. In the ER, he has a bowel movement that is bloody. Temperature is 98.7. He's got a pulse of 100 and a respiratory rate of 20 with a blood pressure of 100 on 65. His weight is 15 kilograms. What is the next step in management? So we'll take a look again through our choices here. And JB has E. Queen has E. And I think, let's go ahead. I don't want to give too much away. Let's pick E. And think to yourself, what's the diagnosis? Very nice. Very nice. So what is the diagnosis here, right? Intussusception. So this is an intussusception. A Meckel's scan is looking for a Meckel's diverticulum. This is like a slow, long-term bleed. It's not going to have that pain where the infant's bringing their knees to their chest. And they say that when the infant is having these on and off crying spells, that's the intestine and the bowel actually telescoping in and out and causing pain with some ischemia. So this is a very standard test question. It is something that you are going to see, and you need to know how to treat it. So nice job. We can go on to the next one here. All right. So which of the following is the best option for anticoagulation for this patient? So we know this is going to be some type of anticoagulation. Is it going to be DVT? Is it going to be a heart valve? Let's find out. Warfarin, dabigatran, clopidogrel, evaluation of renal function prior to beginning any anticoagulation therapy. Think to yourself, what drugs do you need to evaluate renal function for? So what are they getting at there? And then no anticoagulation therapy initiation since patient has a mechanical aortic valve. Okay, so it's probably a valve question. And it's a short stem. So the 77-year-old female with a history of AFib undergoes valve replacement with mechanical valve. So this is a straight up kind of cardiology question. What is the anticoagulation therapy for a patient with a mechanical aortic valve? Or I guess with AFib and has the mechanical valve replacement. Yeah. So 2 indications here. It doesn't specify she's actively in AFib or previously, but a lot of people are putting B. A lot of people are putting B. Let's see. So we can go ahead and put B for this one. Some A. Yeah. So let's go ahead and switch it to A, and then we can show this one. That will be warfarin or Coumadin. So that's the correct answer. So if you have a prosthetic valve of any type, whether it's a bioprosthetic or an actual mechanical valve, you're going to have an increased risk of thrombus, which of course increases your risk of thromboembolism. And so, in these patients, it's kind of just a memorization thing, but vitamin K antagonists, which is your warfarin, they're going to be a first-line agent. There are other options, and again, you will see variety in clinical practice, but your textbook answer for this is warfarin. I chose this one, even though it's a very straightforward, just to prove that sometimes you do have to memorize facts, and there's nothing in this question that could help you navigate through this. If you run into one of these on test day, I do want to remind you, if you don't know what the answer is, don't stress. Again, there's obviously no meat in that stem to pull anything from. Nothing is going to be given away from those answer choices. They are purely asking you, do you know this or not? And if you don't, okay, there's a lot of questions on test day. Take your best guess and move on. So Nice job. Kathleen, got that one right. Very good. Okay. So, what is the primary concern of corticosteroid administration in this patient? So we're giving someone steroids. Let's see, read our choices. Maternal infection, neonatal infection, neonatal adrenal suppression, increased maternal insulin requirement, or term labor. So we have a whole bunch of things to go through here. Let's read our stem. A 30-year-old primogravid female at 28 weeks gestational age presents to the emergency department with contractions that have been occurring every 6 minutes. The patient has a long-standing history of type 1 diabetes, which has complicated her prenatal course. Vaginal exam demonstrates approximately 1 centimeter of cervical dilation and mild cervical effacement. Magnesium sulfate, an antibiotic, and betamethasone are initiated. So the question at the end again is, what is the primary concern of corticosteroid administration in this patient? So ask yourself, why are we giving steroids? What is the point? And then what is the risk benefit? Like, what is that the downside? What is the complication that could occur with this? Go ahead and drop what you think it is in the chat. And remember, sometimes if you don't know or you're not exactly sure, just think back to your basics. So what do steroids do? And then looking at the answer choices, which of those could it affect? And I'll give you a few seconds here. I know it's a tougher one. A few seconds to put your answer in. Yeah, so this is a tough one. People are a little more hesitant to answer, right? Priyan, GJ, Kathleen, all. So Priyan and Kathleen are thinking D, and GJ is thinking C. So the majority here now is thinking it is D. So let's go ahead and put D. And you've done a very nice job. Again, tough question, asking a pretty detailed medication side effect in a rare situation. But again, think back to what steroids do. They cause demargination of your white blood cells, and so you can have a falsely elevated white count, and you also will get hyperglycemia. And what's going to happen with hyperglycemia? High blood sugar, you're going to need some insulin. So it's going to affect the mom. And, based on her history, based on her baseline glucose level, history of diabetes, anything like that is obviously going to affect, what happens. But and I don't want to go too off the rails, but think of what steroids do. Again, the important part in this question that I really want you to take home is remembering steroids and lung maturation for surfactant production. So that's why we're giving it. Obviously, the risk of having neonatal ARDS is much worse than the mom having to take some insulin. So nothing is without risk, and this is a question asking you about a risk benefit. So very good. Okay, so which of the following is the most likely diagnosis? We're going to have to make a diagnosis in this question. Is it ischemic colitis, acute hepatitis, pancreatic adenocarcinoma, sclerosing cholangitis, or an amoebic liver abscess? That's an interesting one. So kind of all over the place. We're going to have to read the stem here. A 15-year-old boy presents with his mother for evaluation of yellow-colored eyes. The patient's mother reports he has had intermittent abdominal pain and diarrhea for 2 years, as well as trouble gaining weight. He is referred to a gastroenterologist. Liver function tests show a bilirubin of 3.5 with 2.8 being conjugated. That means you got to do some math, but your unconjugated is less than the half of that. So ALK phos of 644 and borderline normal transaminases. Right upper quadrant ultrasound is normal. Stool cultures are negative. What is the most likely diagnosis? So this is purely a GI test of your knowledge. He obviously is a 15-year-old kiddo who is jaundiced, yellow color eyes, and we know that this is a direct hyperbilirubinemia because our direct value is considerably higher than our indirect. And again, this is a good time to challenge yourself, or maybe later on tonight, if you're actively studying, go through and remind yourself, what are those indirect causes? Is it hemolysis? What is going on? And for your direct, is there an obstruction? Is there cancer? Remind yourself of the causes of both direct and indirect hyperbilirubinemia and what those look like. So I see some answer choices for D here, sclerosing cholangitis. So we'll go ahead and pick that. Very nice. Very nice. And of course, sclerosing cholangitis is going to obstruct the biliary system. It's going to give you that obstructive pattern with the increased conjugated bilirubin. Again, without diving into the weeds, I generally like to just remember that if the bile sits around longer, it has more time to sit there and get conjugated. And so you're going to have an elevated conjugated bilirubin in diseases that obstruct the bile system. And in diseases like hemolysis, where there's tons of red blood cell breakdown and turnover, but there's easy flow out of the biliary system, you're going to have an increased bilirubin, and you're going to have an increased indirect, but that direct is not going to have time to conjugate. So that's how I think about it. But we can go on to the next question. Again, use these to kind of target your studying. That's really the purpose of questions. It's not necessarily about doing all 2,000 questions. It's about targeting your studying based off of those questions. So let's jump into this one. What is the appropriate course of treatment for long-term management? So I told you about this trick. Appropriate course of treatment for long-term management. I read it again. There you go. Start benzodiazepines. Start a selective serotonin reuptake inhibitor, or an SSRI. No further treatment necessary. Monitor for 24 hours with suicide precautions. So we're going to have to read the stem. We don't know what the diagnosis is. So this is a 31-year-old woman with no significant past medical history. She was physically attacked while walking home from work. This episode occurred over 1 month ago. She continues to have flashbacks and fear of going outside at night, which is not improving. The patient has been exhibiting many signs of depression and now refuses to leave her house. She requires a brief hospitalization, during which psych consult is requested for her nightmares and flashbacks of the event. She states that she has been unable to sleep because of this. The patient is also concerned her fear of leaving her home will inhibit her participation in rehab and physical therapy. What is the most appropriate course of treatment for long-term management? So let's see what you think. Yeah. I'm liking it. So I see, looks like a bunch of B's. So let's go with B. I like it. Start an SSRI. Nice work. And this is about understanding that that long-term management. If someone's having an acute anxiety-provoking episode, is a benzodiazepine going to work? Absolutely. It's going to help abort that panic attack, but it's not the appropriate long-term treatment. And that is, another iteration. You can see the difficulty level here is ranked as hard because many learners are going to look straight past that long-term management component of the STEM, and they're just going to see that this is a anxiety, a panic attack, and they're going to give the benzo, and they're going to be wrong. And so nice job on this question. So we can go ahead on to the next one. Okay. Which of the following is the initial treatment of this condition? Give an intravenous fluid bolus, increase sevoflurane, administer dantrolene, administer cyproheptadine, administer physostigmine. So I always thought this was a cool condition as a medical student. Just reading those choices, I can tell you what it's probably going to be about, but let's read the stem. A 40-year-old man in good health undergoes shoulder arthroscopy. Prior to intubation, he is sedated and paralyzed with propofol and succinylcholine, followed by general anesthesia with sevoflurane. So right now you're probably getting nervous because you're not an anesthesiologist and you might not know these. And if you're not in the ER, you probably don't know any of those drugs. Those are really the only two places that intubate occasionally critical care. So don't get too worried. You'll see what's going on. Just give the stem some time here. 10 minutes later, he develops hypoxemia and his end tidal CO2 begins to rise and continues to rise despite increased ventilation. His heart rate is 88 beats per minute, blood pressure is labile, and temperature is 104. Pretty high for someone who's just laying there during surgery. Exam reveals muscular rigidity, and lab studies show a K of 5.3. The urine appears reddish brown in the urine collection bag. What is the treatment of this condition? So you can drop your answer in there. This is a pretty standard question. Again, this is something that you have a pretty good chance of seeing on boards. And I'll kind of talk about why I put this in here in a second. So I'm seeing a lot of C. Nice. We can go ahead and put C. Great job. And so, yeah, this is malignant hyperthermia. This can occur with anesthesia, multiple different agents, but this patient got a whole bunch. So they got sucks and they got sevoflurane. I'm not an anesthesiologist. I'm not an expert with the different gases. I just know the very basics from medical school. And I'm fortunate that I work in the emergency department. I'm very comfortable with the intubation meds, but for people that don't practice in this setting, this question probably creates a fair amount of anxiety reading those questions. They're talking about pushing propofol, succinylcholine, sevoflurane. Like, you can get overwhelmed really quickly. And again, this goes back to question anatomy. We know we were looking for a condition. None of that actually mattered. I mean, I guess if you want to be formal and look at the drugs that cause malignant hyperthermia, I guess that helps. But even taking that line out, if we go up and look at the stem again, you can totally take out all of the anesthesiology terms, all of the medications. We can just jump to a 40-year-old man in good health undergoes shoulder arthroscopy. Jump down. We can jump all the way down to the point where it says temperature increases to 104, exam reveals muscular rigidity, and then urine appears reddish brown in the collection bag. So, is there other helpful keys in this stem? Yeah, there's a lot of stuff in there that helps. And it's, like I said, this is all full of really good information, but you don't need anything other than what's highlighted here to get the correct answer in this question, in my opinion. So use what you need. Again, try and follow this order, and I think it's really going to help. And let's jump on to our last question. Okay. So before we start this, I want to remind you one more time, there will be a survey at the end. If you could fill that out, we would greatly appreciate it. And of course, this will be recorded. So if you want to go back and these again, you're more than welcome to. And if you have any questions or anything, of course, feel free to reach out to me on social media at See the Med Life. Thank you for hanging out. And I hope this was helpful. So let's get into the last question. What diagnosis is most likely? Testicular feminization syndrome, Turner syndrome, imperforate hymen, prolactinoma, or primary amenorrhea? So I think most people either really like or really don't like the HPA access questions. This is one of them. Get into it. A 17-year-old female is evaluated because she has not yet begun menstruating. Her sister began menstruating at age 13. She is healthy and takes no medications. She denies excessive exercising or dieting. Her height and weight are at the 60th percentile for age. Breast and pubic hair development are Tanner stage 4, and pelvic ultrasound demonstrates a normal uterus and ovaries. What diagnosis is most likely? So I'll give you some time to process that, and then I'll kind of, once we get an answer, and I'll call out some of what's in the stem. Go ahead and drop what you think this is in the chat. And this is a tough one. We're ending on a tough one. So Kathleen going to put a vote for E. I like it. JB voting for E as well. I think that's reasonable. We can select E. Let's see. So nice job. This is a tough question. And like I said, these generally make people pretty nervous, but I want to highlight mainly in the stem. The answer I'm actually not that concerned about. You can study this on your own, but I want to highlight some of the stuff in the stem here that was really important. So this is a 17-year-old female. She hasn't begun menstruating. Sure, we already know. Her sister began menstruating at age 13. So they're telling you something's off, right? There's going to be some kind of a diagnosis here because she does have someone in the family who had normal menstruation at normal age. She's healthy. She's not taking any medications that would affect her HP access. That's why we've got the medication part in there. She's denying any excessive exercise or dieting. That's important because that's obviously a cause that's very well known to affect, initiation and consistency of menstruation. Her height and weight are 60th percentile, essentially totally normal. Why is that important? Well, this could be a PCOS picture, but they're saying she's not heavy. She's not really fitting that development. And then last, but also well, almost last. I guess we'll say the breast and the pubic hair development, Tanner stage 4. I will say, know your Tanner stages. It's one of the reasons why I put this question in here. They seem tedious. Nobody likes to look at those pictures or look at the cartoon drawings. It seems very tedious to memorize them, but they will get you points on test day. And the point is, she is having development of female characteristics. And Tanner stage 4 is, it's kind of hard to like quantify them without the images in front of us, but it's pretty close to like an adult female's body. So she's having sexual development here. Things are kind of progressing in the right direction. And then we do the pelvic ultrasound, which seals the deal. And we have normal uterus and ovaries. The only thing that I will say, and this is a question that is tested very often, the imperforate hymen seems to show up a lot. It's just a popular piece for testing. If you read anything about like pelvic pain, pelvic fullness, kind of like a distended vagina, or anything indicating that, start to think imperforate hymen. And sometimes it's not that intuitive when you read it. It doesn't always click. So that's why I highlight that and I mention that. But there's a lot of good information in this question to break down. Again, these questions, I don't personally like HPA access questions, so I think they're challenging. It's why I put one in. And don't forget, when there's a question that's hard for you, that's an indicator that you need to go and work on that area. And if I was going to, I like cardiology questions very much. I think they're very fun to answer. That means that I have a good knowledge base in that area. I'm very comfortable with it. Endocrine and HPA, I find not as much fun to answer, which means if I was going to go study right now and maximize my points on test day, I would go study endocrine, because that's obviously where I'm weakest and have the best chance of gaining a piece of knowledge that's going to help me on test day. Whereas cardiology, could I take myself from a 9 to a 10? Sure, but I'm already likely to get, let's say, 9 out of 10 correct. Whereas on endocrine, they would only get 5 or 6 correct out of 10. If I bring that to a 7 or an 8, that's a big difference. So think about that. Thank you for coming to hang out with us. This was fun. It's not as interactive here, of course, but I hope this was helpful for you. Some tips and kind of tricks to taking these tests. Like I said, I have a fair amount of experience not only taking them, but writing for them. Thank you again for spending your afternoon or evening with us. You can find me on social media at See the Med Life. And thank you to BoardVitals for having me today. I think this was really fun and helpful.
Thank you for joining us today. If you enjoyed the video, please give it a like and subscribe for more videos. If you are interested in BoardVitals, you can click the link in the description to check out our website.